This is a 45-year-old gentleman who was hospitalized 2 weeks ago for acute pancreatitis, discharged after cholecystectomy. Now the patient presents with pain, fever, leukocytosis. CT scan shows gram-negative rods. Imipenem's begun. After 3 days, the patient is persistently hypotensive tachycardic. What's the next best step? So the important thing here is to recognize is that this is not a pseudocyst. And I would say a third to maybe a half of all radiologists in the country would actually send you reports saying pseudocyst formed. This is not a pseudocyst. If you think it's a pseudocyst is a big bag of fluid, and if it's infected, it's just like pus, and you can drain it any way you want. But this is pancreatic necrosis, and this is infected pancreatic necrosis, and given the day, remember I showed you the evolution of necrosis, at this point, 2 weeks later, two weeks, a little more than 2 weeks later, this is like thick stuff in there. It's not liquefied. So the only way to treat this is surgical drainage. The patient is persistently febrile. He's now hypotensive, so he's clinically unstable. He's got infected necrosis. Only surgery can go in at this time. Don't let the radiologist try screwing around with the catheters. This is a surgical case. So, and the stuff on the right side, well, yeah, your right side too. That stuff, that gooey stuff is floating in the fluid of the cyst. The CT scan, it cannot tell the difference, whether it's fluid or that gook. Now, an MRI and endoscopic ultrasound can differentiate, but most of us are using CTs. You get a CT, radiologist sits there and says, oh, I'll put a catheter in there. You can't put a catheter in walled-off necrosis.